Okay, I'm gonna screen share. My name is Maria Rubolino, and this is my project. I'm gonna move this over here for our population health course, and my topic is on school-based health centers to manage type 1 diabetes. Oops, let me go back. So type 1 diabetes in the school-based health center, that's managing these chronic health conditions for children. These school-based health systems manage a number of different acute and chronic illnesses, but the big ones that the literature reports is diabetes, type 1 diabetes, asthma, obesity, and mental health, and then reproductive concerns. So here's the introduction. So just to give you a little background on diabetes in the pediatric population. So the prevalence of children up to age 19 diagnosed with type 1 diabetes up to 2009 has risen 21%. I couldn't find any new statistics that talked about anything more current, but I am sure that those numbers are probably higher. The American Diabetes Association reports that the number of children that have type 1 diabetes was 17,000, and then between 2011 and 2012, the number of youth with type 2 diabetes was 5,300. So we can see there's a lot. So, and it says overall, there's about 1.2 million children and adults in America that have type 1 diabetes. So we're really focusing on type 1 here because it's the insulin-dependent population. Type 1 diabetes makes up about 5% of cases of diabetes in the US in children, and then somewhere between 1/3 and 1/2 of African American children have and Hispanic have different forms of type 1 diabetes. So, and of course, those races are the more, those higher economic disparities and health disparities. And so they add the risk of diabetes is even higher. So when does diabetes begin to, peak in onset? It's between 5 and 7 years of age, and then around puberty, it seems to peak again. Type 1 diabetes in the pediatric population, by 2050, it is estimated that approximately 600,000 people will be diagnosed with type 1 under the age of 20. So that's a huge number of individuals. So we have to really focus on how we're going to manage these children when they're going to have potentially so many other problems that they have to deal with in their life, and making sure that all their other health needs are met. So distinguishing between type 1 and type 2 diabetes in children is really essential, making sure we have the correct diagnosis, and especially when we're dealing with different ethnic and racial minorities. So when you're talking about diagnosis, it's looking at the A1C level, the fasting glucose level, the peptide levels, looking at autoantibodies, and making sure that that diagnosis is correct, because of course management is different, and making sure that a pediatric endocrinologist is really involved in the care. And we have to think about, some of the Hispanic population. If they're in rural areas, then we have other issues that we're dealing with, because how are they going to get to that pediatric endocrinologist? So sadly, less than 1/3 of the population has type 1 diabetes that will actually achieve, good blood sugar control, so within that target range. So that's what happens to those other 2/3 individuals, that their health can be impacted later on in life, with microvascular complications. School-based health centers, we're talking about those, so kind of put diabetes aside for a second. School-based health centers, they can provide acute and chronic illnesses. They can provide care in the elementary, the middle school, and the high school settings. And these health centers can be located on the premises, or they can be in like an off-campus premise where they may be bused to, or maybe nearby, but they're still linked with the school. So many of these health centers are run by a team, typically of overseeing physician in certain states, and in some states run by the nurse practitioner, but they have usually nurses involved, and medical assistants, and ancillary staff. The team, as I said, can manage a multitude of issues and illnesses, chronic and acute, and that often these centers are in these underinsured, uninsured, or insured by Medicare areas. So that's how they help that community. Of course, not all school sites have these. So current literature supports that school-based health centers increase the overall access to medical care. And for children, there's a correlation that when you increase access to medical care and you increase their health, their academic performance improves. So schools have these type of centers have also reported less absenteeism, higher graduation rates, and a reduction in the number of student dropouts, which is huge. Especially when you're thinking that these are they're serving a lot of the rural health or lower income socioeconomic areas. Studies have also shown that school-based centers result in less emergency room visits and urgent care visits. They've also seen a higher rate of immunizations with those children, which of course with our diabetics, they need their immunizations for that, because if they get sick when they already have, a diabetic illness, they can run into more complications. So overall, school-based health centers can reduce global healthcare costs. So expansion, scholarly evidence. So I've kind of talked a little about scholarly evidence and why this is important, but definitely expansion of the school-based centers is needed. Some are smaller than others. Some only provide like sick day visits. So really expansion is what they need. And in order for, the development of a school-based center, you need community-based needs assessment to be completed in that particular community, determine like at what extent do they need. They can increase access to pediatric health care, especially to the most vulnerable or medically underserved. And currently there's about a little over 2,000 school-based centers in the US, and which is a 20% increase since 2011. But when we're talking about 7 or 8 years, that's still not a huge increase. So the Affordable Care Act, it actually provided funding to expand these health centers to the medically underserved areas. In order for a child to go to one of these school-based health centers, they need parental consent. But unless it's for like reproductive issues where they don't need parental consent. Okay, so what we're talking about, vulnerable populations and who's vulnerable. Well, we have a couple of things. We have children are vulnerable all around. So they're unable to legally and even ethically, consent to be involved in type of research or perform any medical interventions. And then you're talking about, how do children and adults differ? They respond to their medicines differently. Their brains are more immature. They respond to interventions differently, and they interact with their environment differently. So they definitely are more vulnerable in those areas. And then we're talking about socioeconomic inequality. So those most vulnerable, of races and ethnic cultures, individuals that live in that lower socioeconomic status are definitely more vulnerable. And if they're, health disparity, that's more vulnerable too. So vulnerable populations, is that quote, are at risk for disparate health access and outcomes because of economic, cultural, ethnic, and health characteristics. These population include patients who are have racial or ethnic minorities, children, elderly, socioeconomic disadvantage, underinsured, or those with any medical conditions, which that type 1 diabetic, knowing that it's represented more in the African and Hispanic population. So just a brief discussion about type 1 diabetes. And type 1 diabetes, it's a result of the destruction of the beta cell that's located in the pancreas. And, definitely this is immune driven, and which leads to, insulin deficiency or insulin absence of insulin, depending on, what kind of diabetes they have. So the human antigen, which is located on chromosome 6, is responsible for about 50% of the genetic risk of developing type 1 diabetes. But the insulin gene polymorphisms on chromosome 11, and on chromosome 2, they're responsible about 15% of the genetic predisposition. So just to show you here that once an inflammatory response starts to occur, we see this cascade happen, and with the the C cell dysfunction, or the beta cell dysfunction, and then when that beta cell dysfunction happens, the destruction occurs, and then the insulin production changes. So for type 1 diabetes, the epidemiology, there's some thought that viruses, such as if a fetus was exposed to rubella in utero, can play in the role in the environmental triggers to type 1 diabetes. Because remember, it's that inflammatory response that they're thinking is, unless you have that genetic risk a number of studies have reported that if a baby was introduced to cow's milk too soon, because there's insulin in the milk, that it can also trigger an autoimmune response that leads to type 1 diabetes. So I thought that was very interesting. Another study reported that the gut flora can play a role in developing type 1 diabetes, like having an unhealthy gut flora. And then it's widely thought that varying environmental factors have played in the role of type 1 diabetes, such as even low vitamin D and virus exposure. So overall, beta cell destruction in the pancreas leads to cell death, which is often due to an inflammatory reaction, or it could be due to one of the genetic, chromosome. So type 1 diabetes is often diagnosed when there's no family history in children, although a child's risk of developing diabetes type 1 is increased by about 6% if they have a family member that has been diagnosed with type 1. So what happens in that clinical course of diabetes? So the insulin levels are low or absent, and then they cause the plasma glucagon levels to rise. The pancreas doesn't respond because they don't have the insulin to respond, and the Langerhans cells will be destroyed. And then if insulin deficiency becomes severe, osmotic pressure changes due to the diuresis and dehydration may occur. So fatty acid levels can rise, and then you can develop diabetic ketoacidosis. So during that diabetic ketoacidosis state, there can be uncontrolled muscle wasting. So just another picture of kind of the cascading of events with inadequate production of insulin. This is just a picture to show you that, like in stage 1, there's beta cell autoimmunity, but the blood sugar is typically in this normal glycemic state, and typically no symptoms. Stage 2, there's the blood sugars are changing, but pre-symptomatic, and then stage 3, blood sugars are definitely changed, and then they become symptomatic. So you see the cascading of what happens, that they don't get symptomatic right away. Okay, so what do we do about all this information? So definitely helping students and families. We've got to be able to get those children to be able to attend school and have social lives and be able to manage their chronic illness. So the way that I propose to do that with my intervention is definitely with school-based health centers, which is happening in some, but not all. The goal is for the children to have a healthy lifestyle. So children with type 1 and type 2, but especially type 1, need support from the entire medical team. They need their families involved. They need the schools involved, the teachers, if they're getting school lunches. I mean, all that needs to take into account. The ADA recommends an A1C goal of 7.5 or less among all pediatric age groups. And then school-based health centers, like I said, are often run by a nurse practitioner at the school site or nearby. The goal is for the school-based health center to allow the student to help to manage, individually manage their diabetes. And often they'll have to use some telemedicine. So if you're in some rural area, and the parents have to take off work to get the child to the pediatric endocrinologist, wouldn't it be better if the child could utilize those services while they're in the school setting, or during those hours? And you can telehealth with the pediatric endocrinologist, and maybe the nurse practitioner can adjust those dosages of insulin, or maybe work with the nutritionist to adjust their nutrition for their lunch or their breakfast. So there's a lot can be done to really support those families. Type 1 diabetic children should be able to self-monitor their glucose, but I've seen in the school systems where there's been like a LVN that's in the school, and all the children's blood sugars are being transferred information to the LVN's phone, so the LVN can watch their blood sugars for those really brittle diabetics. So medical providers at the school-based centers can collaborate with the school, staff, teachers, especially when they're younger, they can't control their medications, or they don't know how to run their insulin pump, or what happens if their insulin pump fails, those kind of things. So there's a lot of help available when you have those school-based centers. The goal is to meet the needs of the community. I mean, that's really important. So collaborating, developing partnerships, and the school-based centers can provide, daily care for those children rather than just going to appointments every month or every 6 weeks. They can also help those children not develop those lifelong complications, those, vision issues and vascular and all the microvascular issues with kidney damage and things like that. So research has proven that when children have poor health, this will also lead to poor academic performance, and then therefore improved health with the chronic disease is needed. And the centers can help the child spend more time learning and less time out of the school, so they don't have to travel to health appointments, because we can use telemedicine, we can use the NP, and she can help adjust dosages, problem solve if there's, their insulin pump's not working. So there's so many advantages in that. And also putting these school-based centers, I mean, if we're talking that the health disparities are already there, and the ethnic disparities with developing type 1 diabetes, and then you can reduce the health and academic and economic disparities by putting them into those lower socioeconomic areas. So, because absenteeism is a big problem, especially with children when they have a chronic illness, because of their health issues. So they say chronic absenteeism is linked with serious health issues even into adulthood. Their studies have also said that when children have missed a lot of school, they have trouble holding jobs when they're adults. So having that chronic absenteeism be resolved is key. And chronic absenteeism, the definition of that is about missing 10% of the entire school year, which is about 18 days. The reasons for absenteeism could be, excused, like this is a medical reason, or it can be unexcused. Maybe they just weren't feeling well because of their illness, but there's not really due to truancy. So when you have this child that's already medically vulnerable, and then you add the absenteeism and then the academic performance issue, I mean, it's just a cascading of events. So this, it can lead to dropout. So children with chronic illnesses such as asthma and type 1 miss more school when they're having more symptoms. So the better control, the better, they can stay in school. And it's important that both public and private schools, are aware of the federal laws that apply for children with type 1 diabetes and, chronic illnesses like asthma. They may need a 504 plan so that the schools are working with these children to make sure that they can stay healthy and stay in school. And about 12% of parents reported that their child frequently missed school days just because of the diabetes. Okay, so nursing leadership. So this is where our role is. So the DNP prepared nurse can coordinate with the medical community to set up these school-based centers. I mean, doing a needs assessment, contacting the hospitals, the pediatric specialists, the endocrinologists, public health, to be able to really form a good team and work together with the health educators, the case managers, the nutritionists, to help our most vulnerable and make sure they keep their blood sugars in good control to be able to have them perform better in school. The DNP leader must work with also insurance agencies, including Medicaid, to make sure they can generate contracts and billing to make sure that the school-based center is going to get paid, because in the end, sustainability, economic sustainability is key. The DNP leader may function as a nurse practitioner, but she also can serve as a leader over the nurses, the medical assistants, and be working with the physicians to really coordinate the care for those individuals. The ADA says the cost of diabetes between type 1 and type 2 in the US during the year 2017 is $327 billion. So I'm sure 2019, I'm sure it's higher. So each person that diagnosed with diabetes incurs an average of about $16,000 per year in medical expenditures. So if you're talking that cost, and I've been kind of referring to the lower socioeconomic, but even the middle class, you have $20,000 going out in medical expenses a year just for one child. That's, can be huge. And if they're having to take off work to take their children to these visits that may take all day, that, can play even a bigger impact. So this is like 2 to 3 times higher than an average person's cost without having diabetes. So, I mean, it can be a very hard economic impact on the family. Indirect costs for the schools, such as absenteeism related to diabetes, about $3.3 billion annually. And caring for people with diabetes accounts for about 1 in 4 healthcare dollars in the US. So this was really interesting when I looked at operating costs and what it costs to run these programs. I mean, there's a wide range of information. Operating costs of running a school-based health center, they have reports looking at $16,000 a year to about $659,000 per year. I mean, so it's a huge difference. And I can't imagine running a school-based health center on $16,000 a year. Then this Rand and Associates, they did a study where they reviewed multiple other studies and helped school-based health centers. They looked at calculating cost per user. So how much did it cost for that to see that individual during that year? And the cost range from about $142, probably one visit, to $1,802. So that's kind of what their average was. So school-based health centers are definitely facing challenges being economically sustainable. And their mission is to serve all students, not taking into account their insurance status. So the impact would be huge. I mean, we have some that are working great, and we have many schools that don't have them. So focusing on that pediatric population, that is our future. That's our future generation. And if the program is successful in treatment and management of type 1, the children will perceivably have less absenteeism, higher academic performance, less dropouts, less ER visits, less urgent care visits, which places an economic impact. And minimizing how many times children has to go out of town and scheduling appointments, so then that helps the family's financial impact. And several studies have documented that children and adolescents who used a school-based health center have more primary care visits, which is good, and fewer emergency department visits. So that's really good. So what are our causes and initiatives? Our strategies are to delay or prevent type 1 diabetes continues to remain unknown. We don't really know how to prevent it. The ADA reports the importance of understanding that the onset of type 1 diabetes in children is vastly different from diabetes in an adult. And unfortunately, because pediatrics are a vulnerable population, we don't have a lot of research on type 1 diabetes in those children. Therefore, recommendations are based off a limited population or small subset of pediatric children. So of course, the goal is to have bigger trials with this type of population, and the importance of diagnosing a child correctly between type 1 and type 2 is important, and involving pediatric endocrinologists is essential. So research has shown overall that a child that has a chronic health condition will have a decrease in academic achievement. And remember, we're talking about type 1 diabetes. The other big ones they're talking about is mental health issues, obesity, and asthma. Those are kind of the really big ones that they're focusing on, the school-based health centers. And providing a safe environment is really essential, and allowing that child to thrive academically is important. And how do we evaluate if our intervention worked? Does our school-based health system, because there's not a lot of studies that have a direct correlation between you put in a school-based system and children are thriving academically, because trying to figure out what children were treated and things like that. But overall, you'd be looking at, do we have improved health outcomes? Do we have improved blood sugar control? Are they adhering to the vaccine schedule? Because when we're talking to auto antibody disorder, that it's really important that we have herd immunity, we get their immunizations up to date so that they don't develop some other disease process. Are we seeing improved academic performance? Are we seeing healthier lifestyles? Are we seeing families being better educated and more satisfaction with that child's health? Less days absent from school, less days of hospitalization, and less ER visits. And then gaps in the school-based centers. Services, unfortunately, are typically only available during school days or even school hours. Sometimes they're open in the summer, but maybe they don't have transportation because if there's no busing to get there. So that's kind of the downfall of one of the school-based health centers. And parental consent, like I said, unless it's mandated by the state. For reproductive health, they can go in, but typically they have to have parental consent. And they're obviously not available at every school site. If we just have a little over 2,000, they're definitely not at every school site. And that direct link for research saying, do these work? We're seeing these little offsets, excuse me, of information, but trying to figure out, is that direct link, or is it truly making a difference in the end? So further research definitely is needed, and economic sustainability is key. So making sure that these programs that are available not just in a low socioeconomic, but even in rural areas, middle income communities, because these chronic illnesses can devastate a family financially. So in conclusion, it's important to note that when discussing type 1 diabetes, children are not little adults. That's not the way they're treated. Pediatric onset diabetes is definitely different than adult onset diabetes, even type 1. It's distinct in its pathophysiologies, its epidemiology, developmental, and response to therapy. So the CDC reports that academic success is directly related to health and well-being of children. And school centers may remove health disparities by increasing health equity to the disadvantaged population. And by pulling in those school-based health centers, I think we're kind of going in that direction. Chronic health conditions, such as type 1 and the other ones I've mentioned, required elevated levels of preventative health promotion, health screening, and management of disease process. And then here's my references. Okay. Bye. My last one.